grand rounds. It's so good to see people in person again, and even Erin is here today. Yay! Um, I'm just delighted to have Dr. Hager come and introduce today's speaker.
Good afternoon. I am one of the associate program directors for the resident. Oh, well, let's unmute it. Again. Do you think we're working? Great. Perfect. I'll give a little pause. I'm Dr. Hager. I'm a associate program director for the residency program. We'll just confirm that everyone online can hear us, and I'll give our introduction. Go for it. Okay. Well, it is my honor to introduce to you Dr. Ash Bagway. She is a pediatric resident. She is first and foremost a graduate of Rajiv Gandhi Medical College, and now a third-year pediatric resident at the Sanford University of South Dakota School of Medicine residency program. She also is brave enough to be one of our co-chiefs and help with a multitude of tasks in addition to her own education. She is a proud, as many of you know, cat mom to Kiro. And she said she didn't include a picture, but I think if we ask kindly, she'll give us a few stories about him. We are fortunate to hear from her on the epidemic of obesity in the pediatric population, and I am excited to learn what she has to share with us. Please help me in welcoming her.
Hello, everyone. Thank you, Dr. Hager, for those kind words. Yeah, I was contemplating whether I should include a picture of Kiro in my presentation. Didn't know how professional that would be. He is also currently battling with obesity, as my vet tells me. So it would have actually been pretty on point. Thank you, everybody, for coming here in person. I am very excited to be talking about a topic that I feel very passionately about. So let's get into it. So just talking about our topic, I think if you go into the semantics of it all, the term epidemic isn't usually used for anything which is not of infectious origin. It is a term that would be used for an outbreak of something. However, given, as we talk about it, we'll talk about how exponentially prevalent the pediatric obesity is. So comparing it to an epidemic wouldn't be that wrong. I have completed this presentation or made this presentation with the help of Dr. Brock Double D, one of the pediatrics gastroenterologists. Thank you so much for guiding me and hopefully saving me at the end of the presentation during the questions and answers. All right, getting into it, I do not have any financial or other disclosures. I am just a pediatric resident, so. And I think this was very on point. It is Malnutrition Awareness Week by ASPEN, which is the American Society of Parenteral and Enteral Nutrition. Was not, it's just a happy coincidence. Just want to give a shout out to that. And it is there's a Feeding South Dakota drive going on where we can donate things, and I can share more information about that if anybody wants to. Talking about the goals and objectives of our presentation today. So firstly, talking about what is obesity, what is pediatric obesity, going over a few statistics, facts and figures, numbers that I don't really love looking at, but it's important to understand how prevalent it is. Talking a little bit about the etiology of obesity, and then having an overview on non-alcoholic fatty liver disease in pediatrics. And lastly, talking a little bit about the available community resources and just reflections on how do we approach this in our society. So pediatric obesity, it's an important public health problem in the United States as of now with increasing prevalence. And with this increasing prevalence, we also see an increasing prevalence of associated comorbidities, with pediatric obesity. And this can be an enormous burden on obesity related diseases on a global scale and not just national or statewide scale. So, what is obesity? Going over the definitions a little bit. The term overweight is something that we commonly hear, and that is something we would use for an individual who is greater than 85th percentile for BMI, and this would be it should be appropriate for age and sex. When you go into obesity, it can be classified into three classes. Individuals with greater than 95th percentile BMI would be class 1. Class 2 would be individuals with greater than 1/20th percent of the 95th percentile, or BMI greater than or equal to 35 kg per meter square. And then class 3 would be greater than 140% of the 95th percentile, or BMI greater than 40 kgs per meter squares. And calculating all of this is very difficult, and we are very fortunate to have Epic, where you can put the appropriate BMI charts and get these percentile values there. The term morbid obesity is a term that we have commonly heard, and that is a term that is used when individuals with higher BMIs have associated comorbidities. It is a term which is used synonymously with severe obesity also. And severe obesity would be class 2 and 3. And this can be kind of a discouraging term for parents, so it isn't recommended to use the term morbid obesity as much. Now, going into the numbers, 1/3 of the children in the United States are either overweight or obese. And I felt that this was a large number, 1/3. This isn't by any means a small number. And again, looking at the number, the percentages of people, and when I look at the bar graph there, I see that um, the the top portion of it is just going, it's increasing as we get older, which can actually give us a little bit of an idea on what the progression of this disease probably looks like. There are individuals, preschool aged, there are smaller number, and it just keeps going bigger and bigger. And I can only imagine what it will look like in the next 5 or 10 years. This is the trend in obesity from ages 2 to 19 for these years. And again, you can see that it's definitely something. Obesity wasn't as prevalent in the 1960s, even 1980s, and it's just gotten a very steep slope there in the last 2 decades or so. This is a South Dakota specific statistic, which I got from the State of Obesity website, which is a cool website where you can enter whichever state you want to look at the statistics for and get the data accordingly. South Dakota ranks number 10 in the 51 states for obesity in the ages of 2 to 4, which also I think, if we were to rely on the source, it's a pretty big number. 16% rate of obesity amongst the kiddos between ages 2 and 4. And this data is obtained from kids participating in WIC. And then between ages 10 and 17, there is 15.2%, and we rank 28th for South Dakota. So, what is the etiology of obesity? We all have learned about it in med school, and we keep talking about it. But I think it's very important to talk about the environmental factors. And the biggest reason for this would be that the environmental factors are the modifiable ones. These are the ones where interventions can actually give us a good bang for our buck here. This is what we need to really talk about. So, talking about that, the etiology would be, sedentary lifestyle. And I feel very sad when I think about kiddos having sedentary lifestyle. It's something that adults have to have. The people who have desk jobs and 9 to 5 jobs, kids are supposed to be running around. They're not supposed to have a sedentary lifestyle, but they do, and we all know that. And at the risk of putting kiddos in boxes, but kiddos who are obese, when I talk to them, when I ask them what they like to do in their free time, they are usually gamers. They like to watch a lot of TV. They're unfortunately couch potatoes, and that is, I think it shying away from those things isn't really going to help us. The use of media, as I alluded, is a risk factor. And then diet. We don't like to have our kids on a diet, but when you look at it, sugar sweetened beverages is a big component of every kiddo's daily diet. And when you think about, a 14-year-old who's like, yeah, I have a couple of cans of pop a day, what does that mean? That comes to around 270 kcals per day if you look at it. And that is around 10 to 15% of our total calorie intake, depending on how much they eat. And you actually break down these numbers, it's a lot of calories from one can of pop. Sleep related issues. There are good trials and papers out there which say that individuals who have irregular sleep or poor sleep habits tend to have that affects their obesity quite a bit. And I think it's a vicious cycle. People with obesity and to have obstructive sleep apnea, but that also adds to it. And then unfortunately, there are medications that do also predispose you to have obesity. So looking at the, again, this came from the same website, looking at our South Dakota specific data, 14.4% people say that they have a high soda consumption, and I believe high would be greater than two a day, 2 cans a day. A lot of kiddos don't have breakfast. There's low fruit and low vegetable consumption, and this is just, and we can talk a little bit more about it as we go further. When we talk about high computer usage, there's 37.3% for computer usage and low PE participation. And what was really interesting to me, and I would love to be corrected and be wrong about this, that only high schoolers in South Dakota are required to participate in PE. Middle schoolers and elementary schoolers are not required, for whatever I could find. And that was really interesting for me. If you're not, it is, I understand that there are lots of individuals who cannot necessarily live up to the demands that a PE class would have. However, making it required could help us a lot here. And of course, cannot talk about obesity without at least talking about the other etiologies. There are obviously genetic factors, familial factors. Not every obese child is the same. Not every obese child is eating too much. There are things that can cause them to be obese, and we don't want to just brush that off either. There are lots of endocrine disorders and metabolic programming, which means there are big environmental and nutritional factors that influence a child during critical periods of development, which kind of sets them on the track of becoming obese later in life. And that is what metabolic programming, in a very like gross way, is explained. Um, all right, so now going to kind of the main topic at hand here, obesity and liver diseases. Why are we talking about the liver? As we know, obesity affects all our body organs and body systems, and it's not good for anything. But particularly talking about the liver as it's one of the things that we can talk about. So, pediatric non-alcoholic fatty liver disease, or NAFLD, as it could be called, it's a spectrum of chronic liver diseases for people under 18 years of age, which results from excessive fat accumulation in the liver. And the exemption to that is in the absence of a secondary cause of hepatic steatosis. And the secondary causes could be alcohol consumption, viral infections like hepatitis C, parenteral nutrition. It could be inborn errors of metabolism. It could be lipodystrophy. So anything that we know causes fat accumulation in the liver in the absence of that. And what is excessive fat? If we were to quantify it, it would be fat percent of greater than 5% in the liver. And this is to be obtained by either imaging, a direct quantification, and the direct quantification would be like postmortem, and or histological estimation is how it's calculated. It is typically associated with insulin resistance, central or generalized obesity, dyslipidemia. So usually comes with a lot of associated comorbidities. It is the most common liver disease in the United States, which is one of the biggest reasons why it's important to talk about it. It really is the disease there. And it is also a leading indication for adult liver transplant, and specifically young adult liver transplant. So when you think about it, 10 years ago, these young adults were pediatric population, and they probably had fatty liver, and they progressed into a disease which needed liver transplant. So, I believe it's a pretty significant thing that we need to talk about. Now, just a quick discussion on the nomenclature of the disease. So, non-alcoholic fatty liver disease, why was it called that? So, if you look into it, the history of it, adults, everything we have, the data is from the adult world. And in the adult world, there were people who had the same histological appearance as an alcoholic liver disease individual would have. However, they were teetotalers and had never touched alcohol. So the term non-alcoholic fatty liver disease came into existence. Now, I would hope that none of our patient population really is an alcoholic. I mean, I know that the older patients that we do see could be, but I would say that this term is not very inclusive of the pediatric world. So, there are a few groups and blogs that I've read where they recommend using nutrition-associated fatty liver disease as an alternative. And it just like fits with my OCD where the acronym is maintained, but we're actually using it in a different way. And I will not take credit for this terminology. It is something I just came across in a podcast that I was listening to. So, it could be called NAFLD still. So, what is NAFLD and what is included in it? So, there is NAFL, so NAFL, which is non alcoholic or nutrition associated fatty liver, where there is steatosis without any specific changes that suggest us of any inflammation or fibrosis. So, what it says is there's excess fat in the body, which is hanging out in the liver, and the liver is fine with it. The liver is like, okay, fat, hang out with me, it's fine. But it's when, the liver doesn't really want it. And it's when the liver is like, nah, I don't, I'm going to rebel against you, is when we start having inflammation. And that's where we progress to NASH. So hepatic steatosis with inflammation and any kind of injuries to the hepatocytes or the hepatic lobules. And if we like think about way back to our histology days, where we think about the histology of a hepatic lobule, there are zones, and zone 3 is in the center. Zone 1 is on the outside, and that's another way of grading it. And we don't really need to go into it. NAFLD, so NASH or NAFL with fibrosis, would is one of the progressions, and then there is with cirrhosis. So this would be the progression and what is included in the whole spectrum. Before we go into NAFLD, just kind of making note of the differential diagnoses for hepatic steatosis. So what is not NAFLD? So it could be, the reasons could be a lot of them. There is genetic and metabolic disorders. There's a long list of these. We all studied them for step 1. There is infections, hepatitis C. There are lots of medications which do promote steatosis in the liver. And then there could be dietary causes, be it, parental nutrition, like I talked about before, and malnutrition. So just to make note that whenever you are calling and you are talking about fatty liver in a pediatric patient, you want to make absolutely sure that they don't have any of these, because you don't want to tell somebody with Wilson's disease that they need to lose weight to fix their liver. That's not going to happen. That's not going to fix it. So you make sure that we know about these. So now talking about the prevalence, in kiddos from ages 2 to 4, there's a prevalence of 0.7%, which isn't high or low, it's a fact. And it usually varies in ethnicity. So there's a 4-fold increase in hepatic steatosis in the Hispanic population. White and Asian children have a higher incidence as compared to African American children. So this does tell us that there is a definite genetic association to this, and there is a male predominance. We look at when we look at the facts, we do know that obesity is more prevalent in our males also. So there's a predominance there, and it's higher in obese children. And I felt it important to mention this because there is there's lean NAFLD in kiddos who are not obese. So they have, without going too much into it, they have other genetic reasons which are causing them to have steatosis. Now, whether to call it whether to include it in NAFLD or not is a topic of debate, which we don't really need to get into. The comorbidities associated with NAFLD would be obstructive sleep apnea, associated with obesity, type 2 diabetes, and panhypopituitarism is also seen. So what are the barriers in recognition and management of NAFLD? The biggest reason we have any barriers is because there's a huge blind spot in what is the natural history of NAFLD. It is very underexplored in the pediatric world. It is actually underexplored even in the adult world, but getting there more than the pediatric world. We don't know much about the enough about the prevalence. The data that we have is very cross-sectional. What we do need is a longitudinal data, and the biggest reason why we don't have that is because these children transition into adult care and then are, not in our research cohorts. So there is a lot of underdiagnoses in these children because of under recognition, not appropriate screening, and just a lack of appreciation of the complications. We do appreciate that a kiddo has obesity, but we don't necessarily always talk about the complications. Not, and we might talk about them with amongst ourselves, but definitely not with the families. And then there are limitations to treatment options. Again, the adult world always gets all the treatment options, and then they slowly trickle down and come to the world of pediatrics. So I would say these are the biggest barriers that we have. There's definite need for like a pertinent research in developing good screening methods, good management methods. So definitely a big part of um, liver diseases that needs to be explored. So why do we worry about this? So like I said, there's fat in the liver, it's hanging out, it's not doing anything, that's fine. But when it progresses to NASH, when it progresses to inflammation, the liver has kind of declared itself. The liver has said, I don't want the fat here, and I'm going to now start acting up. So if a child has any level of fibrosis or inflammation, it's just a bad trajectory and it is going to progress to liver failure. There is no way of that it is not going to. And that progression is usually pretty fast and it's going to have inevitable disease. So just recognizing this, I think, is very important. And the incidence and prevalence of obesity is increasing, which tells us that the incidence and prevalence of fatty liver is increasing. Um, and like I mentioned previously, this is just fueling the fire for young adult liver transplants. So talking about screening, it's very important to detect it before the onset of irreversible liver disease. Liver is that one unique organ which it likes to live. So it regenerates and it is able to, fight off all the insult that it gets. However, it's it does, there is an end stage to it and we don't want to get there. The choice of test and the screening recommendations are per NASPGHAN, which is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And the recommendation or the guidance that they provide is what I have used for this presentation. So the choice of test is ALT. It is a universally available test. It is acceptable and it's minimally invasive. It is just a blood draw, which I know in the world of pediatrics, nothing is just a blood draw, but it is a blood draw. It's not bigger than that. And the cutoff levels for that would be 26 milligram per deciliter for boys and 22 for girls. For the diagnosis of NAFLD, for any individual to have the spectrum, the cutoff would be 2 times the usual cutoff. So it would be 50 for boys and 44 for girls. And if anybody has an ALT greater than 80 and has obesity in conjunction with that, you can almost safely assume that they are likely progress to NASH. AST and GGD are not well studied for the purposes of screening. So if an individual has a positive AST and a GGD, but a normal ALT, it's very unlikely that they have NAFLD. However, if any individuals with higher ALT have a higher AST and a higher GGT, then it's likely that they're going to have bad histology. That distinction makes sense. So in regards to imaging, routinely done is ultrasonography, and there is a low sensitivity and specificity for it, especially in kiddos with lower degree of steatosis. It is not very easy to say that this is a good test, and it's not accurate for quantification at all. It's more accurate would be MRI or MRS. However, they're expensive, as we all know, and there's a lack of valid cutoffs because this is so underexplored. We don't know what is normal and how we quantify that even then. And CT scans are also better, but again, putting the kiddo at a risk of radiation just for screening is not something that we typically do. So who do we screen? So broadly speaking, we're talking about kiddos who are overweight and obese per the definitions, as I mentioned earlier. Non-overweight kiddos who have risk factors could also be included. So kiddos with central adiposity, insulin resistance, prediabetes or diabetes, dyslipidemia, sleep apnea, or a family history of NAFLD or NASH would be good individuals. And when to screen is another question. The NASPGHAN says between the ages of 9 and 11. And if you look at this number, there's one thing that we do between the ages of 9 and 11, and that is our lipid screening. So I don't think it was. The purpose of this was to club it with the lipid screening that we do. You know, you're going to be poking your kiddos for the lipid screen anyway, that's universally done, so or recommended anyway, so might as well get that ALT there. It can be considered in young patients with an extremely high BMI or with risk factors. And the recommendation is to repeat the test in every 2 to 3 years if it is initially normal and the risk factors are still present. So the risk factors would again be being overweight or family history and otherwise. So say you have patients who have a higher ALT, what would you do? You would recommend lifestyle modifications. This is what we usually do, even with our lipid panels being, abnormal. You talk about lifestyle modifications, you ask them to make changes, and you recheck it, and you recheck it in 3 months and see where it's at. When you recheck it in 3 months, hopefully it's lower, but I know this is being very unrealistic. So if it is higher, so now we go into the flow chart where any child greater than 8, so between 9 and 11 or older, if they have a chronically elevated ALT, and this would be mean over 3 months after some lifestyle changes were attempted, and they are obese or overweight and asymptomatic. So when you say asymptomatic, you think about the red flags. And what are the red flags? It would be um, chronic fatigue, GI bleeding of any sort, jaundice, splenomegaly, abnormal exams or abnormal labs. Any of these labs, if these are abnormal, then you, of course, don't just wait it out. But if they don't have any red flags, you look at the ALT level at the 3 month mark. If that ALT is upper limit of normal, you think about, do they have any signs or symptoms of liver disease? If they do not, then you again encourage lifestyle modification and recheck it. And there are not good guidelines that tell you when to recheck at that point, and that's always the problem. But I would assume anywhere between 6 to 12 months would be appropriate. But if they do have any signs or symptoms, then you of course refer them for further testing or refer them to pediatrics, GI, or hepatology. If the ALT at that point is greater than 2 times the upper limit of normal or greater than 80, then you pretty much slam dunk refer them to PGI, and they need to undergo further testing. Anytime there's any kind of recommendation, there's always a recommendation to follow clinical judgment. These are, again, this is not set rules, these are recs. So what are the additional testings that is typically done? There are screening labs. So there is CBC with DIF. You get the other components of a CMP. You get their GGT, INR, so to look at the synthetic function and such for the liver. And you also get the HbA1c because these individuals are likely obese. You want to rule out infections, so you want to rule out any hepatitis. You want to rule out endocrine disorders, rule out autoimmune disorders. So you want to get your celiac panel, make sure they don't have that. You want to rule out your genetic causes. Again, this does end up being a diagnosis of exclusion. You want to make sure none of the other things are the reason. And in regards to imaging, you could do an ultrasonography or MRI based on the clinical picture. So like I keep saying, excluding monogenic causes of this all is extremely important. And these would be the list of things that do cause the similar presentation. So how is diagnosis done? What is like the final gold standard? And that would be a liver biopsy. And as we all know, liver biopsies are very, very invasive. There is a lot of procedural risk, bleeding risk, but this is how you would for sure know that a kiddo has NAFLD, NASH, whichever. However, there is a limitation to this. The fat in the liver is not necessarily all over, it is patchy. And what if you don't get the right part of the liver? biopsied. You're not getting the whole liver out, of course. So there is a limitation to that given the non-uniform nature of the disease. And so a biopsy is typically done when there is an increased risk of NASH or advanced fibrosis. And this increased risk would truly be a family history of very high ALT, the clinical presentation. And the other thing that benefits, we get a benefit from the biopsy is you figure out if we have autoimmune hepatitis or not. And autoimmune hepatitis is also one of those where cannot be clinically excluded, and biopsy is the only way to include or exclude it. So you want to make sure they don't have that either. So, what is our goal with our treatment options? We want regression of steatosis, inflammation, and fibrosis. That is our primary goal. We're not going to be unrealistic here and talk about resolution first. We want regression. We want to go in a stepwise fashion, try to, well, I would say the first goal is to stop the progression, then to go into regression, and then hopefully resolution. Decrease in ALT is something that a lot of providers might chase. From whatever I could read, it was considered a surrogate marker. There isn't enough clinical data telling us that decrease in ALT is reflective of disease improvement. However, we do not have good non-invasive biomarkers that would tell us either. So I guess ALT is the one we rely on. And the overarching goal, we're not just treating one disease or one organ, we are treating that individual. So the overarching goal would be to improve the dyslipidemia, the insulin resistance, and maintain good blood pressures and things like that. So the management for all of this, there is no pharmacotherapy available which is approved for the pediatric world, which keep makes we have had our hands tied that way. Hopefully soon there will be medications that would be approved soon, and those would be things that are working on the feedback loop of the bile acid type sequencing, the lipogenesis, anti-fibrotic things, but lots of clinical trials are ongoing for these things, but nothing's been approved yet. So really, weight management and lifestyle modification is the only thing we can do. And there are lots and lots of studies and papers which show that this can be very, very effective in reversing NAFLD and also reversing NASH, which is big. I know that as providers, we do like having pharmacotherapies available to treat something. We want to fix something. However, if you actually look at it, fixing a disease by lifestyle modification without pumping somebody with medications isn't really that bad an alternative. It is difficult, but it's not that bad. And talking about aggressive treatment options for kiddos with extremely severe obesity, intensive weight management, so literally like going into the medical weight management, multidisciplinary referrals, and bariatric surgery. And it's really hard to know which individuals would need this because there is an uncertainty in the prognosis, uncertainty in the progression of the disease. You can't really quantify anything. So it's challenging to determine who will need or benefit from an aggressive approach. However, these are options that are available. It would be sad for me to think of a 16-year-old who needed a bariatric surgery or a gastric sleeve, but if that's what they need, that's what they need. Lifestyle changes. This is, I'm just like saying like a broken record. This is something we keep saying in the Gen Peds world every time, but this really is what makes a difference. And avoidance of sugar sweetened beverages, like the number one thing that I read universally. Everybody says that healthy, well balanced diet, moderate to high intensity exercise, and less than 2 hours of screen time. Now, when you look at this list, how many of us really think that a patient or child is going to be able to make all of this? It is very unrealistic. And if you expect your child to do everything, you're actually setting them up for failure and they're not going to do anything. Going baby steps one at a time, try to maybe do one thing and see how that changes. And then maybe try to do another thing. And if there was one thing that I would say to stop, it would be sugar sweetened beverages. That really is. And I'll talk a little bit about that. So when you talk about unhealthy food, it is always cheaper and easier to access. I will get much more for $5 from McDonald's than I would get from Hy-Vee. And I don't mean to hate on McDonald's. I love hash browns, but it's a fact. Everybody knows this, and that just makes it so much difficult to tell families in poor socioeconomic situations that, hey, you need to eat healthy where they're trying to save money, but also feed their child. It's very difficult, and a lecture here is not going to fix that. But one thing that can fix it is, and this is a jingle that I've heard on a podcast, is if it is sweet and you can pour it, kick it out the door. That's simple as that. If it is sweet and it's drinkable, just out. And I think, we can sit and make a huge long list of things that kiddos should avoid and put a lot of stress on the moms. But if you say this one thing, we can see how many things change. It's a standard of living where we're just drinking a glass of juice, or just don't do it. There was a time when juice was considered a healthy snack alternative, but we now all know that it isn't. AAP has come out with guidelines that say no juice to less than 2 year olds. So, just apply it to everyone. Um, would be something we could try. And then just talking about the additional screening, so cardiovascular screening for kiddos, and hopefully this is already done, but something to make sure is done is screening for dyslipidemia, screening their blood pressures, A1C as we talked about, and if the A1C is abnormal, considering glucose tolerance test or referrals to endocrinology and things like that. So, how does long-term care look for kiddos with NAFL, anybody in NAFL D? So they need to be monitored at least annually, and this is all these things are important for everybody to know, subspecialists and primary care providers to know, because if you have a kiddo with something like this, there should, it takes a village to make sure it's being done. Maybe they missed their GI appointments 2 times in a row, but they keep coming back for sports physicals, so that's the time you get them. So more frequent visits are known to cause better weight management. So kiddos who you diagnose with obesity and you're working on weight management, it is recommended to try to see them on a monthly follow-up to just talk about what they did better. They're almost becoming their health coach, but that is what is needed. A repeat biopsy every 2 to 3 years, if the first one is abnormal and there is an ongoing risk factor. The secondhand smoke is known to worsen the NASH progression, so definitely counseling on that. These kiddos should be well immunized for hepatitis A and B, and then baseline liver enzyme should always be obtained for before starting any hepatotoxic medications. There should always be a high index of suspicion for psychosocial issues. Like I keep talking about, obesity is not a medical issue only. It is a more societal and social issue, and there should be something that we look into always. So talking about the prognosis, a kiddo has started getting fatty liver and is getting inflammation and fibrosis. It's never good. Anybody who presents with this in a pediatric age group, it's considered to be a more aggressive phenotype than it would be for adults. And the data does say that only few children have rapid progression to death, transplant, and cardiovascular disease. However, I don't really know if we can rely on that, because these kids become adults and then they don't come in our pediatric data. But these events don't happen before the age of 21, which is why the pediatric data set is saying that they don't progress to death, but they probably do. So what do we do? We kind of talked about a lot of things. We talked about the screening, but what do we do for obesity? What resources do we have? And most of us hear about this, and this is mostly for the med students and the residents out there to know what national programs are available. So there is WIC, as we all know, Women, Infants, and Children program. There is SNAP, or the Food Stamps program, which was administered by the USDA. That gives families short-term financial support for food. There's Healthy Food Financing Initiative, which is a public and private partnership which provides loans or grants to people to construct grocery stores, which is so important, and we'll talk a little bit about that later. There is the Child and Adult Care Food Program, which provides funding to childcare or adult care centers to have them provide good nutrition. And even Head Start and Early Starter programs, which can participate in this and actively engage the people who come there for obesity prevention and talk to families. So these are good resources that we know of, but just to know that we should use them. A few more numbers from the same website as before. It's very South Dakota specific about how many individuals are participating in the SNAP program, how many of them are children, how many National School Lunch Program children are participating in the National School Lunch Program, and then how many are participating in WIC. I won't go into like the numbers of it all, but we have a good amount of participation, is what my conclusion was looking at some of the neighboring states. So talking about food deserts, what are those? So these are areas where the people who live there have low access to a food retailer. And I was talking about this with Dr. Nelson last week, and she said that there was a Hy-Vee in Sioux Falls which closed down, and there was a huge part in, I believe it's the northeast side of Sioux Falls, that became a food desert, where there wasn't a grocery store close by. And if you talk about, Sioux Falls, me, when I came to Sioux Falls, I was like, there's a grocery store so close to each other. Like, this is good. But if you actually think about it, for people who don't have access to cars, have to walk to grocery stores for in the middle of winter, it's not easy to get to a supermarket. It's not easy to get to a grocery store. When that happens, you would usually try to maybe go to a gas station because that's closer or easily available, and because there are always gas stations in most towns, and the food there is typically pricier, and it is also always unhealthy because they don't really have fresh groceries. And if I was sitting and thinking about it, why are there so many gas stations but there are not enough grocery stores? And when you think about it, most of these cities have national highways that go through them, and national highways need to have gas stations because that supplies things and across the country, and that is beneficial to if you really go into capitalism, which I don't want to, but if you really think about that, that is why we have gas stations and gas station grocery stores and not regular ones. And there was a nice paper that I read where it said that, and it was a Midwest study which said supermarkets typically have lower costs for things like bread and meat and things like that, but local grocery stores have lower costs for um, fresh produce, fruits and vegetables. As some of us who have gone to the farmers market here, we know that you get cheaper fresh produce there. So kind of encouraging those. And then this is a map looking at all the food deserts in South Dakota, and you can see there are loads, there are lots of them, and lots of people who do not have good access to good food. And it is really it's something that we need to realize, that eating well or even eating is a privilege which not a lot of us recognize. um, so talking about the community resources, this is a list of all the Sioux Falls resources, and we go to some of them as residents in our community medicine block in the first year. So lots of places which either provide food or fresh hot meals to individuals who may be in need. But this is the list of Sioux Falls resources. If you want to think about the other resources, there's this very cool website that is the helplinecenter.org. You can call them if you don't have access to internet, or and talk about the same resources, or you can go to the website. And I actually went on it, and if you look at it, um, the step one is to just enter the zip code, and I entered the zip code for Rosebud if I was thinking of going West River and trying to look at that. And then you hit food, or there are lots of resources for everything, and then there's a list of things. So if I hit food pantries, there were at least 4 food pantries that were available in that area. If I look at soup kitchens, there were a couple meal sites that people could go to get good food. So, just something to remember, just something that you might have to encourage families or anybody to use. And this is more talking about like the big things, proposed changes to the South Dakota system. So encouraging healthy food financing initiatives. So more, and the healthy food financing initiative is to the grants to build more grocery stores, laws preempting local policies related to nutrition, making PE a requirement in elementary and middle for middle schoolers and elementary schoolers, which I think would be beneficial. And then updating the licensing laws. And the one big thing I thought of was the food marketing policies. A lot of unhealthy foods are advertised to children. And you see the Chester cheetah on Cheetos and you want to eat Cheetos. And how are you gonna it everybody I like Cheetos. So it's just this marketing, it is targeting kiddos, and it is making them want to eat all the unhealthy things. Um, so talking about conclusions and reflections, broad strokes, as long as there's like economic disparities, there's always going to be social and health disparities. That is something that we have to be well aware of. And it is our responsibility as people in the position of privilege to try to bridge that gap. Um, should we really be blaming that one kid who is obese for his liver, or should we really be making this a more societal discussion? It's a societal problem. It's not a problem that a family is facing. It's not a problem that a state is. It's a global. It's a societal issue. If you talk about societal issues need societal solutions. It cannot just be not letting that one kid drink lemonade. It is more than that. And again, you know, being aware that and kiddo, I know that in primary care visits we have a lot of things to talk about, but talking about food security is definitely a big one that I do sometimes think we gloss over. Oops. These are my references. The last one is the podcast that I keep mentioning. It's awesome. It's called Bowel Sounds. If anybody is interested in GI or just want to learn more about GI, go listen to it. It's free. It's by Naxagan. Yeah, this would be time for questions.
Well, Ash, I guess sadly I probably know the research world more than I know the pediatric care world for the older kids. And so I was curious because I know there's a lot of normative data in using bod pod or like pea pods and bod pods to follow kids and their risk for obesity and NAFLD over time. Did you see any clinical studies where that's coming into the clinical world, or have you seen any applications of that yet? Oh, I'm sorry. A bod pod is a body composition measurement, and there's actually normative data on how much fat should be in a liver at each age. So there are long-term studies. It doesn't require any radiation. It's a 5-minute test. It's an air plasmography, where it's just kind of even safer than DEXA. And so I just was curious. I know that's really how they follow this, like in the research setting for developmental program of metabolic disease. So I was curious if does anybody have experience with that clinically yet, or is that just at
They're research center
research
based.
centers?
Yeah.
Okay.
They're very, very expensive.
Yeah. Yeah, buy some here but anyway, for some research, but I just was curious.
No, I saw them in fellowship. I saw them at one at the University of Minnesota, I
They
believe.
still
But
have a bunch of them.
yeah,
Okay, I just was curious if that was coming. I don't know.
The only place I've seen that is a dedicated obesity
Centers.
research / program.
Mhm.
They're not cheap. Is what they're saying.
Yeah.
And if you think about the prevalence of pediatric obesity, how many of these would you need in each clinic, and how long you need? Simple 5 minutes. 5 minutes out of a clinic visit. That's good.
Oh, I'm just thinking for at-risk, children, like just as a screening tool that could be done. I just was curious.
In the interest of full disclosure, I do love me some good station. When I'm thinking about all this, we certainly see a lot of kids for deconditioning, shortness of breath, and all this, because they're out of shape and overweight. And it's usually the whole family's involved. And without getting the whole family involved in the changes that dietary changes, all this stuff, it's just not successful. It's just so frustrating. But also wonder about our kids with spontaneous circulations or diastolic dysfunction, where their venous pressures are elevated. They've got to be at increased risk compared to the general population. We look at them regularly for cirrhosis, so we really take this. First for adults.
I can imagine. That's an interesting one.
their inability to exercise at the level that you need to achieve for aerobic conditioning has got to be lower, I would think.
As a rule, it is. Some are exceptions, but as a rule, yeah.
If I correlate what I read, every paper that I read said that dietary modification wins over encouraging an exercise. Because as we all know, we're very rarely going to be able to burn off all of the calories that we overeat, but not eating them might be more easy. So I wonder if that's, yeah.
I think the flip side to that, though, is there's longitudinal data of people who lost weight successfully, kept it off, doing it by diet alone. And in my world of insulin, the exercise will have an immediate impact. 10 minutes of starting to exercise, risk at less than an hour. You see that in other things like just sport. So I think both are necessary. The challenge is, and I think it's spot on, you got to get the whole family to change. You got to have the family change their shopping habits, so they're not buying the ice cream sitting in. And that, I'm pessimistic, but I can think of 3 families that have come in my career and have actually really nailed this whole family stuff. And actually had one kid come up and some of it actually is okay, fine.
I guess, and maybe Aaron can remember the date, but I do remember like when Ordana, they did away with PE in the schools, and we went to legislature to kind of talk about that in the Board of Regents, but I think it was like 2007 or so. Do you guys remember?
I don't recall.
I think a lot of the schools still have it.
Yes, but it's not
That's not
required. The requirement went away. I just was curious if, but I remember there was a statewide push to not do that, but it went through. Just a plug for advocates out there to get back out there. And then the other question I had when I was thinking about Bill's question is, do they follow preterm babies with PNALD long-term? Are they at higher risk of this coming back, or is it just go in and they don't ever have preterm? Oh, sorry, parental nutrition associated, TPN associated.
There's way too many abbreviations.
Sorry.
Yeah.
Sorry.
There's not a specific known correlation between the two.
Okay, so when they grow up, they usually do okay,
The,
although they're at risk for obesity.
yeah, that they are, but the penile, it has a different progression. It's a different road.
Interesting. Interesting topic. Good job.
Just a couple points that are probably relevant. AP has a fairly what labs do you want to screen for helping mention like every couple of years. One of the things that actually just suggests is, boy, it's really easy if you can set up an order set for this with all one. Do we have that? All right, so that may be something that could be a parting gift.
Yeah.
Hold on. Thank you. I appreciate it.
Other couple of, who here has heard of the choosing wisely? All right, if you haven't, look it up. This is professional boards, professional societies, and getting together. Okay, in our world, our specialty, what are the top 10 things we waste money on that we should never ever do in the first place? A lot of them fit here. So if you have a kid with obesity, if this happens, we girls through this all the time. If they're growing well, it's not endocrine. So you should not waste the money to get a kid or cortisol. So it's not going to change what you do. Both the underlying issue. What you should do is do the screening period. And you touch on something. I saw TSH and stuff up there. I would not do that. Same thing for, you should screen for diabetes or pre-diabetes. That is not an A1C. If you look at what AAP says, you get a fasting blood sugar, you get a random blood sugar. That's actually going to pick it up. By the time the A1C has been up, that blood sugar is high continuously for a long time. You miss that boat.
Nice job, man.
Yeah.